Greetings and welcome to this module on macrolide antibiotics in Medicine Beyond Harrison's series in antibiotic topic. We'll discuss beyond the antibacterial action of macrolide antibiotics, its side effects, the use cases for a practicing physicians and critical care consultant. So it's completely for educational purposes. Let's get started. So macrolides are still matters. This is the most misunderstood class of antibiotic. It is not chosen for its strength, but for its strategic advantage. So it covers the atypical organisms so that it is used as a gap fillers. When beta-lactams can kill the typical organisms with cell wall, these macrolides are used as a gap fillers which kill the atypical organisms such as Mycoplasma, Legionella. It is used for immunomodulation. It has macrolides such as Clarithro Azithromycin has immunomodulatory action. So it reduces the effect of cytokines and acts as a lung protector also, increases the surfactant effect. So mortality benefit in selected syndromes. So these are not backup drugs. There are adjunctive strategies in select cases. So drugs in these classes currently used are azithromycin, clarithromycin, erythromycin, and rofithromycin. Erythromycin is now not predominantly used as an antibiotic drug. It is nowadays predominantly used as a prokinetic drug for gastroparesis. And roxithromycin, based on the regional availability, not mostly commonly used in India, mainly for the OPD use cases. So while azithromycin and clarithromycin are the currently used macrolide antibiotics of this class, of which azithromycin is the most used for community-acquired pneumonia, ICU pneumonia, sepsis adjunct, and also one of the drug of choice for Salmonella typhi, even for MDR Salmonella typhi. Clarithromycin can also be used for community-acquired pneumonia. It is part of the H. pylori eradication regimens. So azithromycin dominates in ICU in case of community-acquired pneumonia, ICU pneumonia, not for other use cases. And inpatient practice also it's used. The mechanism of action is, as we all know, it's a 50S ribosomal subunit inhibitor. It inhibits protein synthesis of the bacteria. So it acts as an exit tunnel blockade, same as clindamycin. It's primarily again a bacteriostatic drug because it does not lyse the cell wall. Can be bactericidal at high intracellular concentration, of which more toxicity predominates rather than the bactericidal action. So activity depends more on the intracellular accumulation than the serum levels. So spectrum, these are the organisms that we target when you give a macrolide antibiotic, such as Mycoplasma, Chlamydophila pneumonia, and Legionella, Campylobacter, Bordetella. All these are atypical organisms. It also has a moderate action on Streptococcus pneumonia and Streptococcus pyogenes, whereas very poor action against ESBL, Carbamazepine resistance, Enterobacteriaceae, other enterobacterial pseudomonas. These are almost there is no action for these organisms, be macrolides. So atypical pathogens, macrolides are the first line of choice for these organisms that lack a cell wall, and the organisms that lie intracellularly and are not covered by beta-lactams. For all these, macrolides are one of the first choice. So it covers Mycoplasma, Chlamydia, and Legionella. All these three are not covered by the beta-lactam. So this again reinforces that the usage of beta-lactam along with the macrolide in the treatment of a community-acquired pneumonia. So it also has immunomodulatory action, that is, it reduces the neutrophil recruitment, suppresses cytokine production like mainly IL-6, IL-8, TNF alpha. So it reduces mucus and improves the phagocytosis. So effects occurs even when bacteria are macrolide resistant. So these cases can be used to reduce the toxicity of the infection and reduce the inflammatory markers and mediators to improve the survival outcome also. So these are dual advantage, act as an antibacterial as well as an immunomodulatory. So it reduces mortality in community-acquired pneumonia, consistently seen in moderate, severe, and ICU-acquired community-acquired pneumonia. The benefit persists despite macrolide resistance. Why? Because of the anti-inflammatory action, not just because of the antimicrobial action. So immunomodulation action is not being discussed predominantly across communities. So it has a good amount of immunomodulation, which is highly useful, more than even the killing power of the antibacterial drug. So for community-acquired pneumonia treatment, current guidelines suggest that you have to go with a beta-lactam with the macrolide, or you can just directly go for a respiratory phenocronolone in non-severe community-acquired pneumonia. In case of severe community-acquired pneumonia, there is no role for phenocronolones. Go just directly to beta-lactam with macrolide. So superior outcomes are there in beta-lactam with macrolide group rather than combining beta-lactam with fluoroquinolones. So according to IDSA and ATS guidelines. So if when the macrolide is contraindicated or having potential side effects in that patient, can prefer a tetracycline, just doxycycline. It's also equally beneficial. So for that, we have to know what is the adverse effects and the contraindications for a macrolide antibiotic that we'll go through in the upcoming slides. So why not fluoroquinolones? What are the advantages of macrolides? That will decide why we don't use fluoroquinolones. Because macrolides have lower resistance pressure, no rapid target mutation, no tendon or aortic toxicity, and better immunomodulatory profile. This makes the macrolide the most preferred combination therapy in case of treatment of community pneumonia. It is physiologically a smarter regimen to go with. So sepsis, not primary for a gram-negative coverage, can be used when pneumonia is the suspected source. Only that. So never use this as a monotherapy when you suspect a sepsis. So benefit, it can suppress the cytokine, and it can reduce inflammatory lung injury also. So it's only used as an adjunct and not a monotherapy in case of a sepsis. So in ICU also we use azithromycin or clarithromycin in specific use cases such as severe community acquired pneumonia, post-influenza bacterial pneumonia, Legionella, aspiration pneumonia, and select ARDS with infected triggers. Use this in ICU also. The pharmacokinetics, why azithromycin wins in the race, because very high tissue penetration and very long intracellular half-life, highly preferred once daily dosing, and minimal renal adjustment is required. These four profile of this drug makes this the azithromycin the most pharmacokinetic friendly and ICU friendly molecule. So contraindications, this is where you must be cautious. So in most patients who are elderly, more than 70 years, there will be some coronary artery disease. They will also have electrolyte abnormalities, may lead to QT prolongation. So always take an ECG and look for QT prolongation, and look for other coronary artery disease or heart issues before giving an macrolide antibiotic. So concerns are largely overstated in modern data, which is benefit. So actually don't go for a macrolide when you suspect when you have a QT prolongation. So we can go for a tetracycline. This is doxycycline instead. Again, for myasthenia gravis, it will lead to very severe exacerbation, so avoid it. Again, for erythromycin, don't give in myasthenia gravis. High risk of QT prolongation, even torsades pointis, and acute hepatic injury. Don't give erythromycin. So risk factors of our torsade pointis is prolonged baseline QT, rare history of torsades, and hypokalemia, hypomagnesemia, and concomitant QT prolonging drugs. So highest risk is erythromycin and not azithromycin. Anyways, don't go for a macrolide antibiotic as a whole when you have a QT prolongation. So drug-drug interaction, these are very weak, moderate PGP, peak glycoprotein inhibitor, may increase the level of PGP substrates. So it has a very relevant narrow therapeutic index drugs such as colchicine. Otherwise, there is no much drug-drug interaction. It is much safer than erythromycin in polypharmacy or ICU patients. So yeah, for erythromycin, it is a potent inhibitor of even cytochrome enzymes like 1A2 and 3A4. It's a very moderate to strong inhibitor. Cytochrome 1A2 is irreversible inhibitor, and also PGP inhibitor, which is irreversible. So even 250 milligram single dose will lead to 60% inhibition of cytochrome P3A4, and 800 milligram per day for 4 days will lead to more than 90% suppression. Recovery takes almost 3 to 5 days. So these metabolite creates stable complexes, and that's why uh, don't go for an erythromycin drug. So that is also the reason which has why erythromycin has gone out of favor for usage as an antibiotic. So side effects, most side effects are actually well tolerated. It's a extremely favorable safety profile compared to erythromycin. Always has, along with other drugs, it also can cause nausea and diarrhea. Mild transaminitis is very common, and the cholestatic pattern of liver enzyme injuries is also common. There's very low risk of Clostridium difficile infection risk as with any other antibiotic. Rare cases of phototoxicity are reported. Major toxicity of erythromycin, GI intolerance is very common. QT prolongation and torsady, cholestatic pattern of hepatitis with more than 14-day use. So all these factors again make erythromycin not a good drug of choice. So it can also cause rash and reversible ototoxicity if used IV. So GI symptoms are due to motility irritation. Okay, and so that is also nowadays these side effects are used for as a prokinetic agent based on endoscopic procedures. So spectrum, so gram-positive erythro actually covers better than azithromycin, and for all others, azithromycin are better than erythromycin. So for staph aureus, it can cover for 70% of MSSA, and the group A, B, C, strep and streptococcus pneumonia also it's covered by this drug. So azithromycin, H influenza and Moraxella catarrhalis can be covered by these drugs. And again for atypicals, Mycoplasma, chlamydia, Legionella, Coxiella, and Bordetella. So azithromycin, erythromycin, this macrolide group are jack of all trades, but yet it's not the master of anything. So master of none. So jack of all trades and master of none. So clinical uses of azithromycin. It can be used as again as a atypical coverage. It has mortality benefit in severe cap, and Legionella pneumonia is used as a high dose and for COPD exacerbation. So continue azithromycin even if a beta-lactam sensitive pathogen is identified in a community acquired pneumonia due to immunomodulation benefits. So even if you identified organism which is sensitive to beta-lactam drug, you can again always continue azithromycin along with it for a community acquired pneumonia. So now erythromycin is mainly used as a prokinetic drug for gastroparesis, such as diabetic or post-surgical. So can be used as an incidental coverage, provide an antimicrobial coverage in specific scenarios such as COPD exacerbation, ICU patient already on erythromycin for gut motility. Don't start an erythromycin drug just for the sake of an antibiotic coverage. So azithromycin is oral bioavailability is very poor, only 37%. So it's not so preferred in critical illness. So you can consider doxycycline as an alternative in some community acquired pneumonia cases and COPD exacerbations. Even in elderly with QT prolongation and coronary artery disease, heart issues, go for an doxycycline instead of an azithromycin. So dosing is for community acquired pneumonia, it's 500 mg IV daily for 3 days uploaded, front loaded with it has a long tissue half-life, prolonged effect rather even after stopping is there. So just for 3 days it's given azithromycin. For Legionella pneumonia alone, it can be continued for even 5 to 10 days. It requires longer duration for the intracellular indication of Legionella pneumonia. For erythromycin, it's 250 milligram IV over 5 to 30 minutes for pre-endoscopy, and timing is 20 to 30 minutes before the scoping. This clears the blood and food for better visualization. So pre-endoscopy it can be used as well as prokinetic as 200 milligram IV thrice daily. It's given as only as a slow infusion around 20 minutes. Tachyphylaxis develops within 3 days, so the effect wears off so rapidly. The prokinetic effect. So, but for other drugs for prokinetics, rather than using erythromycin, such as rucalopride, cisapride, mosapride, or even acloxamide, all these drugs are beneficial compared to erythromycin. So erythromycin as an antibiotic, which is rarely used nowadays, are given as 500 milligram to 1000 milligram IV Q6 hourly infused over 20 to 30, 60 minutes. In case of renal dysfunction, more than 10 to 15 GFR, you can go for regular dosing. If in less than 10 to 15, try to avoid erythromycin because of increased total toxicity, and you can go up to only maximum of 2 gram per day and reduce dose 50% if GFR is less than 10. So, note on azithromycin pharmacology. It has 749 weight is 749 grams per mole. Which is a lipophilic drug with oral bioavailability of only 37%. 50% is protein bound with a massive tissue distribution of 30 liters per kg. So, high volume of distribution to the tissues. So, it is a highly intracellular accumulation. Makes this a preferable choice for killing intracellular organisms with a minimal hepatic metabolism. Elimination is only by biliary. Only 6% is renal. Even less than 6% would be agreeable. After it's around 2 days, it's very least concentrated in the urine and it is not going to the CSF, so not a good choice for urinary tract infection as well as CNS infections. So erythromycin, again, it's a 734 gram molecule with oral bioavailability of 20 to 45%, with high protein bound of 80 to 93%, with a very low volume of distribution. Leukocyte accumulation is there more than 40 times the plasma. It accumulates in the leukocytes. Metabolism is by cytochrome P3A4, which is 12%. Acid hydrolysis forms acid hydrolysis elements, potent cytochrome inhibitors. So half-life of 1.5 to 2 hours in case of renal failure. It increases in renal failure. So common misuses, avoid using macrolides for gram-negative sepsis. It can be used as monotherapy in, don't use this as a monotherapy in community acquired pneumonia, severe community acquired pneumonia. In case of erythromycin usage, don't use it for more than 3 days. There is no benefit, only tachyphylaxis occurs. Ignoring this QT and electrolyte status is the major red flag before using a macrolide antibiotic, so try to avoid that. So just in case you need a summary, so it's used for atypical coverage, for immunomodulation, and for community acquired pneumonia mortality benefit. These are the only use cases currently in clinical practice. And avoid it when you go for a broad spectrum gram-negative bactericidal effect, or when you suspect an ESBL or carbapenem resistant central bacteriaceae. So take-home messages are macrolides are strategic adjuncts and not the first-line agents. It is used mainly as an adjunct therapy. Azithromycin is ICU preferred in case you are going for a macrolide antibiotic. Benefits go beyond antimicrobial killing with immunomodulatory effects. It's given for short courses in correct context for the maximal benefit. So these are taken from IDSA and Mandel Douglas Bennett textbook and Sanford guide and up to date. Hope you learned a lot in this macrolide antibiotics and use it with confidence. We'll meet in another video on this antibiotic series. If you're new to this channel, do subscribe. This is Medicine Beyond Harrison's. Thank you for watching.